Uh, Good morning. This is an interesting case which came to our OPD. Basically, a 6-year, 5-month-old female who presented to us with multiple bony swellings and not gaining adequate height and weight. So she had come with her father, and this was his main complaint, that she's having these multiple bony swellings and she's not gaining height. So the problem started at 3 years of age when the father noticed that the girl has the small swelling on the left wrist. It was a bony swelling, it was not mobile, it was painless, and it was causing very minimal restriction of movement. She was able to use her hand, but very minimal, she was causing problem in her movement. And according to him, it was progressing from the hands, then which led up to the shoulder, and then ultimately led to the knees. And there were multiple small swellings which were being formed in these areas. Now, after the knee swelling, there was a deformity. He was seeing that the knees were coming closer to each other progressively, but till the age of 6 years, 5 months. Now, there was no history of any fractures, no history of any seizures or any tetany, no history of any birth injury, no history of any receiving any 3-monthly IV medication to look for any other diagnosis, and no history of any precocity such as any early breast development, bleeding PV, or any birthmarks.
So what do you mean by 3-monthly IV medication?
So basically, I wanted to ask whether she is receiving any bisphosphonates or any medication like that, which could lead me to a diagnosis of any other sorts. So this is basically the family tree. Now, this information I got from the father. The mother was not there. Now, according to the father has 5 siblings. Sorry, 6 siblings, out of which one is a sister. All 5 brothers are affected. According to the father, none of his parents, like his mother's side, were affected, and none of the mother's side, according to the father, affected. So over here we can see like both males and females are affected in 2 generations. So probably an autosomal dominant type character. Now, coming to the basic examination, the birth history actually he could not give it properly. According to him, she was a little low birthed, but we don't know exactly what exactly happened at that time. Examination, her vitals were stable. Anthropometry showed like the height was really low, minus 2.5 SDS at 100.6 centimeters at 6 years, 5 months. MPH was 139.6. Weight was very low, 13 kgs, which is minus 4 SDS. US SLS ratio was 0.9. And head circumference was 51. She was pre-pubertal, and I could not find any capsule and macules on her body. Now, this is her photograph. She basically, if you can see her, first is the bony swelling in the posterior inferior left axilla, which can be seen from the back. There is a cubitus varus deformity of the left elbow. There is widening of the left wrist. There is a bony swelling of the right axilla, which is not visible clearly on this photograph. You can see there's a bony swelling on the left knee. And there's, on examination, which is quite clear also, there's a malleolar swelling of the left lower limb. On the side, you can see there's a lumbar lordosis, and one thing very clear was these bony protuberances on bilateral costochondral junction. Both sides there were these bony protuberances. Hands were this, but though no particular swelling I could find on the hands per se, but left wrist definitely had a swelling. And the father also had similar phenotype, in the sense he was short. You could see there's a deformity of the left elbow, even on the right side. Yeah. So summarizing the history, 6-year, 5-month-old female with multiple painless bony swellings, progressive deformity of knees, and similar deformities in the parent side, in the father's side. So I'll come to the differentials later. Initially, the investigation showed normal, in the sense the normal calcium profile, calcium phosphorus, ALP, electrolytes were normal, thyroid profile was normal. Now, coming to the X-ray, as it could be seen, like there was a bony protrusion from the left elbow. Spine per se was normal, but that elbow protrusion can be seen from here as well. We can see bony protrusions from lower femur, upper tibia, as well as fibula. Here we can see the bony protrusion in the ulna and the curving of the radius. This is another spine photograph. So coming to the differentials, now we have multiple bony swellings which are arising from inside the bone. So any differential of multiple bony swellings, first of all, which comes to mind, multiple osteochondromas. So these are the first which comes in hereditary multiple exostosis. Second is metachondromatosis, Langer-Gideon syndrome, and multiple enchondromas. I will be discussing these differentials later. I've got points against and for these. But coming to the diagnosis per se, the first which comes to is multiple osteochondromas, which is HME, but hereditary multiple exostosis. Now, what exactly is this? An osteochondroma or exostosis is a benign swelling. It is a cartilage capped bony outgrowth. So it has both cortex and medulla, and it's coming out of the core bone. It can either be sessile or pedunculated. Like in this form, it is a pedunculated form. And the most common site is the lateral side of the most active growth plate of the long bone. So as we saw in this patient also, all of them were in ends of long bones rather than middle. It is a monogenic loss of mutation causing for EXT1 and EXT2. It is an autosomal dominant. It can be because of haploinsufficiency and loss of heterozygosity. And one postulated cause is that disturbed heparin sulfate synthesis levels, which causes abnormal chondrocyte function. So clinical features, they manifest mostly when the child is growing. So in growing bones is there. And as we saw in our patient also, distal femur, proximal tibia, fibula, all long bones are involved most commonly. So one very characteristic is often first discovered in the ribs, which is also in our patient. Now, since facial bones are ossified by membranous ossification, they are never seen in facial bones. Only because chondrocyte formation is there, so only long bones are involved. Something very peculiar, which was not in our patient, is pain. So pain is very common because of nerve impingement in these patients. But there's no pain in our patient, and she also didn't complain of much restricted motion. So deformities, commonly forearm, as we can see here, unbalanced growth of the radius and decreased growth of ulna, causing a Madelung type of deformity. Second is hand brachydactyly, angular deformity in pseudomallet fingers, which I did not really find in our patient. Hip, there can be coxa valga, knee, genu valgum, which was present in our patient. Progression of the angular might lead to patellar problems as well as patellofemoral problems. Other issues such as neurovascular impingement, such as pain, paresthesias, functional impairment, vascular compression, there's complaint of sudden increase of pains, which are thrombosis and claudications. One thing we need to be clear in our patient, these costal exostosis can lead to spontaneous hemothorax. So any respiratory disturbance in this patient, she needs to come back immediately. When she grows up, she can have obstetric complications such as complicated delivery. And of course, any child with short stature and deformities, psychosocial problems can be important. One very severe complication of these problems is a malignant degeneration. So they transform into secondary peripheral chondrosarcoma. And based on whatever literature there's a risk up to 25% in these cases. Now, it is more common in the axial skeletons, such as pelvis, scapula, femur. So it's not you cannot pick up by just examining the patient because these are hidden. And these develop from the cartilage cap of the existing osteochondroma. So it is from the existing lesion, whatever is on the top of the cap, it will develop into a carcinoma. So symptoms will be sudden increase in pain, sudden increase in pressure symptoms, and signs on radiology, you will find that there are, obviously on examination, you'll find there are surface irregularities. This patient had moderately smooth the surface. And radiologically, unorganized chalk deposits and light areas, of course, definitive diagnosis is biopsy. Diagnosis, of course, if we know that there's a family history, better to do genetic screening. Clinical, as we saw in this patient. Imaging, X-ray, CT. So X-ray is helpful for an appendicular system, such as hands, feet. Whereas CT is more for the axial skeletons, such as pelvis or scapula. Now, the importance of MRI, it is given as the cartilage cap thickness more than 1 centimeter is a high risk for malignant transformation. So, various screening programs are told for these patients, which I will be discussing. Of course, by MRI, you can see the effect on surrounding structures, and you can see the continuity of the lesion from the core bone. So that is an important thing. PET is, of course, to see malignant because there will be increasing metabolic activity. And bone scintigraphy is not as good as PET, but if PET is not available, they mention that bone scintigraphy can be done. Now, as I discussed differentials, our most common, most probable diagnosis is HME. But other come to metachondromatosis, Langer-Gideon, and multiple enchondroma, that is Olliers disease. So metachondriomatosis is the most common and the second diagnosis. But what happens in this? They most commonly occur in small bones of hand and feet. So mostly in the hands, and what they do, they are of normal statures. They will not have bone shortening or short stature. Now, Langerhans, it has multiple exostosis, but they have a very typical trichorhinopharyngeal syndrome like facies, which was not in this patient. Now, another important thing which we thought is, and quite common disease, is the Olliers disease. But what happens in this? This is a tumor of the hyaline cartilage. So what happens is it grows from inside, and it causes expansion of the phalanges of the hand. It's not like an outgrowth. It basically going from the inside. Olliers disease and Maffucci syndrome is same, but Maffucci has hemangiomas as well. So this sort of ruled out because of the distribution of the lesions and type of lesions. So a screening has been in these patients. Screening has been thought of, saying that periodic screening every 6 to 12 months, first clinically and then radiologically if you feel something is new. Because simple procedures can resolve simple growth disturbances, and we need to monitor the spine, etc., to see any impingement or not. And they say, this Roach et al., he did a study, and he's saying that columnar, like spinal X-ray every second year should be done. Spinal MRI should be done in these patients every 2 years. And in adults, every second year, MRI should be done. If MRI cannot be done, then bone scintigraphy is recommended. The treatment in these cases, if the girl is or the boy is not complaining or anything, actually it is conservative. You need not do anything. However, if there is a problem, you do surgical excision, and it is easy. You just excise from the base. And only there are, if any deformities, you do osteotomies and bone lengthening. Malignant transformation, which I said, it is common, but simple thing, it is low grade. In this, it's never high grade tumor. So you simply excise the tumor and it actually helps in resolution. Experimental treatments such as tripyranol, which is Indian hedgehog inhibitor, and heparinase, which these are all experimental, but no basic studies are there for this.